thank you for joining us tonight. The Division of Pre-Hospital Care at Albany Med is happy to be able to host this protocol update. There'll be two parts. The first will be a BLS protocol update. We'll do that. It'll start with me, Dr. Dailey, Regional EMS Medical Director and Chief of Pre-Hospital Medicine here at Albany Med. I'm going to do the first part of the protocol update, and then Dr. Donovan, who's one of my associates, is going to continue the BLS update. And then Dr. Cordy and I will do the ALS update after a short break. We're being recorded on Facebook Live because we had some AV problems. I apologize for that, but hopefully we'll be able to get all of this out where it needs to go. A couple of things going into the protocol update that I think are really important for everybody to remember. The BLS protocols were updated here for the first time in 20 years. That's a long time for a single set of medical protocols to remain unchanged. And because it was so long, there's a drastic change. For those of you that are going to go look at the document, it looks really, really different than what you saw before. A lot of the stuff that's been removed, you'll recognize is really just extraneous information. So we chose not to put the same information on every slide, or sorry, on every page of the protocol, telling you over and over and over again what really is standard medical care for your patients. At the root of all of the changes to the BLS protocols is that we wanted to have the best medicine possible for the citizens of the state of New York, and we wanted to have the best guidance possible for our EMS providers. So the protocols that you have that are now published on the state website, they're good medicine. All of these protocols follow along with the National Scope of Practice model that's promulgated by the National Highway Traffic Safety Administration. So it's right in line with everything that someone should have learned in EMT school, which will make it a lot easier for you to provide care. These protocols are really all about common sense, and they'll guide that quality care exactly the way you want to provide it. And when you're using these for quality review, remember that patients are taken care of under these protocols with the goal that we're giving them the best medicine possible. These are guides to quality care. A couple of things that are important. There are some protocols in here that specifically authorize excuse me, our providers to do the right thing. In fact, I jokingly call one of the protocols the Do the Right Thing protocol. We'll get to that towards the end. Also, that you'll notice throughout the protocol, there are sections where it says, if equipped and trained. This leaves the decision-making about whether or not to put an intervention out there for an agency up to either that agency itself or up to the region. So all of the things that are available in the protocols may not be at your agency and are not necessarily the standard of care, but are additional options that can be a part of providing care at an agency. We started with a general approach to patient care. And I can't think of anything that would be more deadly for all of you watching this than for me to go through and read each one of these slides. That would be a terrible idea. But take a look at the general approach to patient care, the way it flows. This is exactly what you're taught in EMT class. That's why we did it this way. So it provides that guideline once, right in the beginning of the protocol set. So if you have any questions about how a call can flow, or you want to use this for orienting new members, all of that information is right there. We also highlight ideas like shelter in place and how to make sure what additional support resources may be available. This is not an all-encompassing list of the resources that may be available to you on a call. It's a list of some of those resources. Each region, each city may have different resources available. And some may not have these resources. Many places in the state don't have the luxury that Remo does of having the ability to call an EMS physician to the scene if they need them. When we start looking at things like the primary and secondary survey, we go through all of the elements that you learned in EMT class. This, again, is a guide to care. Care should be based on the training that you received in class, the training that you've done ongoing in your agency, and above all, your common sense. We all know that we say airway, breathing, and circulation, right? But really, when we see that patient, we address the immediate life threats that we see in front of us at the time that we see them. So if an artery is spurting, you're going to put your hand on that artery. This is not necessarily a linear process. As you get into the secondary survey and you continue elements of that patient care, again, this is all the things that you were already trained to do. And we only put it in the protocol set once. Secondary survey, we try to encourage people to make sure to remember things like the MOLST, the EMOLST, and the DNR, not because we anticipate every patient will have one, but because we want you to think about it. Because these are documents that make a big difference to patient care and aren't necessarily things that you face on a day-to-day basis. So when someone's reviewing their protocols, this gives them a chance to consider other things that may be a part of that patient care that can really contribute to how that patient receives care in the hospital. In terms of charting and thinking about taking care of patients, simple elements of a history of present illness. This is not necessarily the way to do it. When we say use sample, OPQRST, or similar to guide an approach to events, illness, and complaint, that's because you may have learned something that's a little bit different. We don't mandate any one of these standards. We just want to make sure that you get a good understanding of what occurred that led to EMS being called, so we can appropriately take care of the patient throughout the care continuum. We also want to make sure that a physical exam is then done that's guided to the complaint that the patient has. That's important. And that's the way we talk about it in the protocols, so that when we ultimately see quality assurance done, as long as the exam is done that's focused to that patient complaint and patient presentation, that's the right thing. We're not asking for other elements. We're providing a guide to care. Now, when we get to the general approach to transportation, this is a little bit different, because what we want to make sure that EMS providers are doing is also focusing on the safety of the transportation process. EMS involves transportation, and thinking about how that can be done as safely as possible is really an important element of care. The one time we can hurt the most people, unfortunately, within EMS is actually operating that ambulance. We want to make sure that people are thinking about that. We want to make sure people are considering all the resources that could be available to them and how to get in and out of any scene. We also talk about safety restraining devices. This is really, really important. This hasn't been written down before. And you know that right now in New York State we're having a real focus on pediatric care, and we have pediatric care coordinators at agencies and in regions. But the time that we can most injure a child is actually when they're not secured appropriately on a stretcher. And something that we are now protocolizing and saying may not is that parents may not hold a child in their arms or in their lap. What we must use is appropriate child seats or safety restraining devices. We want to make sure that we're moving kids as safely as possible in order to make sure that the system is serving them as well. Most of our patients are not children. We need to make sure that we can take care of these small, vulnerable patients when we have them. Some things we've been talking about for a long, long time. Oxygen. When I started in EMS, everybody got oxygen. You sprain your ankle, you get oxygen because it'll help you. We've learned better. Our patients have learned better. Our patients know oxygen, it doesn't help the pain. It may be nice to breathe a little oxygen from time to time, but it doesn't necessarily help that complaint. Now, we're guiding oxygen therapy to what the needs of the patient are. Use pulse oxygenation as your guide. Maintain oxygen saturations of greater than 94%. Because if you do, that's just good medicine. Use a nasal cannula. Use a face mask. Whatever tool you need in order to maintain that saturation at greater than 94. Also, we make note that there are some patients that live with saturations lower than 94% all the time. In particular, kids that have chronic cardiac conditions may live with saturations between 65 and 85%, and that's normal for them. So find out what their normal baseline saturation is and maintain that using the devices that are appropriate. With infants, be really careful. Use really small amounts of oxygen because they're only taking small amounts of air into their lungs. So don't give them lots and lots of oxygen. And use your clinical judgment. The one other time the clinical judgment applies in oxygen administration is trauma patients. Trauma patients may be hypoventilatory, right? You may not be able to get good vital signs on them or good pulse oxygenation. Err on the side of administering oxygen to give that nitrogen washout in case we need to do more interventions later, because that's just better medicine. Other things, CPAP, continuous positive airway pressure. Your agency may offer this at the basic life support level. It doesn't have to. This isn't equipped and trained. This is something that we won't necessarily be moving out to every basic life support agency because that's not prudent fiscal management of the system. But there may be places where basic life support squads are putting CPAP in place because it's good medicine. Also, portable transport ventilators can be used at the basic life support level with a face mask. It's actually really nice to be able to hold a mask sealed tight on a patient and have the automatic transport vent ventilate that patient for you without having to worry about squeezing a bag and maintaining a seal. You can actually do a better job of managing that patient's airway. CPR. So let's think about CPR for a second. CPR works. It works really well if you compress hard, deep, and fast. About 100 times a minute, never taking breaks or breaking only for ventilations. It does not work well in ambulances. And if you do CPR in an ambulance, you're potentially risking the lives of your crew because you can't secure someone appropriately in the back of an ambulance while they're doing CPR. We're getting closer and closer to saying absolutely not. What we said in the protocols this time is the compressions in moving ambulances pose a significant danger to providers, are less effective, and should be avoided. We don't say must, we say should, because we recognize there will be extenuating circumstances where you're forced with the need to do CPR in the back of an ambulance for any number of reasons. But we also say that we can terminate cardiac arrest after 20 minutes. Potentially. Each arrest is different. Each arrest should be considered independently. Contact medical control, because that gives you the opportunity to play through the medical decision making and provide the best care possible for your patient. The other end of the continuum is obvious death. Patients that are dead stay dead. And we want to make sure that people feel comfortable with holding resuscitative measures if that's the right answer for their patient. At any time in this, a provider can call for medical control to get some help and advice. And we're always perfectly happy to answer those questions. But if a patient's got a valid advance directive, like a MOLST, an EMOLST, or a DNR, that says no resuscitative efforts, that's what we do. We do no resuscitative efforts. The other standard or traditional things about withholding resuscitation, decomposition, rigor mortis, dependent lividity, injuries not compatible with life, that's a difficult subjective one. And that one you may want to talk to a doctor about. Let's face it, decapitation is easy, right? Head's over there, body's over here, no resuscitation. But the big thoracic injury is sometimes a little harder to recognize whether or not that really is fatal. All right, so that's one you may want to talk to us about. Submersion in water for greater than an hour. Most of the time, that is going to be something we will consider an obvious death. Right? I say most of the time. Sometimes these are a little different. But leave everything in place if there's anything on that patient already, if we secure that cardiac arrest. And notify law enforcement, because they're going to be a party taking care of the patient from here. All right, I'm going to take a break here. Dr. Donovan's going to take over. Thank you.
All right, thanks, Michael. So at this stage, we're going to be going through some of the actual specific aspects of different protocols. So we'll start it off with good old altered mental status. So historically, a lot of times providers would think to check finger-stick glucose levels on known diabetics, but as time's gone on, we've realized that there's a lot of other conditions that cause hypoglycemic or low blood sugar conditions. Some of those would be, medication overdoses, and the big one would be sepsis. So if you come along a patient that is altered, one can obtain a finger stick glucose, and then if you obtain a number less than 60, on the caveat that the patient has an intact swallow mechanism, then you're free to go ahead and administer glucose or some complex carbohydrates. And then while we're on this protocol, it's also worth mentioning to consider some alternative protocols, such as behavioral issues or ingestion, such as toxic overdoses. Moving on, the next fairly significant protocol would be anaphylaxis. So hopefully we've all read and learned a bit about anaphylaxis or may have encountered it in day-to-day practice. The first take-home point is to make sure that you allow a patient to remain in their position of comfort. So if you have somebody that's leaning forward, working to breathe, this is not the time you want to lay them down flat on their back. If they're in severe distress, you would want to go and utilize the extremist protocol. So this is a patient that would be often in a kind of peri-arrest condition where you're going to actively take over and manage their airway with BVM ventilations. If you're not at that quite level, but you're concerned for a severe respiratory distress, maybe they have some swelling up in the airway, some stridor, and or any low blood pressure, you can consider administering an auto-injector. And the big take-home point for the auto-injector dosing is going to be to remember that 30 kilograms. And as long as someone is greater than or equal to 30 kilograms, you'll be utilizing the adult dosing, which is 0.3 milligrams IM, and this can be given with an auto-injector, or if your region or agency allows for, you can substitute a check and inject syringe, which a lot of local agencies are utilizing. If the patient has a history of anaphylaxis and they tell you, unfortunately I just ate a peanut butter sandwich, I didn't realize this, I'm deathly allergic to peanuts, then definitely indications to go ahead and get the epinephrine on board early. And then you also have the option for repeating in 5 minutes if they have not had any significant improvement, noting that will probably be a very long 5 minutes from a mental perspective. In addition to that, if a patient is wheezing, you can administer albuterol, 2.5 milligrams, and can repeat this up to 3 doses if necessary. One thing worth mentioning, most anaphylactic or severe allergic reactions will have some form of hive, itch, or respiratory symptoms, but you can get isolated just GI symptoms. So if somebody tells you they have a known allergy, they may have ingested something and they're complaining of severe abdominal pain, nausea, vomiting, maybe some diarrhea, and if they're hypotensive, then that could be a consideration for administer of epinephrine. At the BLS or EMT level, you would want to call medical control, run it by them, and just make sure that they agree with that plan of action. And then just a quick note on dosing. So again, if we're treating an adult or a large child that's 30 kilograms or over, you're going to be using the 0.3 milligram dose, or 300 micrograms. And then if you have a smaller individual, such as a young child, you'll be using half of that dose, so 0.15 milligrams. Moving on to carbon monoxide. So these are kind of scenarios where if you're called to monoxide alarm going off in a house or potentially a fire situation, consider potential for carbon monoxide exposure. And if there's ever any doubt, we'd recommend commencing high flow oxygen. This is particularly important for pregnant females because you can monitor a pregnant female and get a carbon monoxide level on her, but that's not truly going to highlight the level of carbon monoxide exposure to the fetus. So in these sort of scenarios, we err on the side of launching treatment. Now, patients with carbon monoxide can either be symptomatic or asymptomatic. First, we'll chat about those that are asymptomatic. So if you have someone that's completely asymptomatic and you have the capability to measure carbon monoxide level in the field, the number we start getting concerned about is percentages greater than 25, which should prompt high flow oxygen and mandatory transport to hospital. There is a potential if you had a lower level exposure, which would be defined as a carbon monoxide level of 12 to 25. You can initiate high flow oxygen on scene and then recheck levels, and then provided these are downtrending, you could consider an RMA or not transporting to hospital, but make sure that you factor in that the patient desires this pathway. So if the patient does want to go to hospital and get checked out, then that would again equal mandatory transport. Now, symptomatic patients are a different kind of kettle of fish, and some of these symptoms are very non-specific, so this can be a little bit challenging to determine if they're actually symptomatic from carbon monoxide. Some of the more common are dizziness, nausea, or confusion. And the big take-home point with symptomatic carbon monoxide exposure is any level of symptomatology should prompt initiation of oxygen and then transport to hospital. If in the setting of a burn, if there's no soot in the airway and you have CPAP, you can initiate this therapy. Although note that if there's any concerns for significant upper airway burns, we'd recommend that you hold off on this with a theoretical potential for barotrauma. And lastly, if you have multiple patients, which may be a common finding for large households, or if you had a large, if an apartment building caught on fire, we'd recommend that if you are dealing with a lot of patients, to contact medical control, and then you can always consider having a physician respond on scene, if you had 5 or 6 plus patients, just to help you kind of sort out and risk stratify on who should be transported versus who could stay. There are some patients that are even higher risk, so we chatted previously about pregnant patients, but also those that are markedly altered or have any hard neurologic findings. So if you find somebody in a house fire and they're having seizure-like activity, that's very concerning, as well, in addition to elevated readings greater than 25%. We chatted very briefly about higher levels in pregnant females, and it's worthwhile noting that a typical smoker can have a carbon monoxide level of up to around 10%. And then one other comment is just to make sure that you don't tape the sensor to a finger, because they're quite that's what I'm looking for. Testy devices, and you want to give them every chance for an accurate measurement. So moving on to any cardiac-related problems, and this is kind of bread and butter, chest pain-related calls. So if you think it's appropriate, perform airway management and initiate oxygen therapy, remembering what Dr. Dailey said a few minutes ago, that not all patients now require 100% oxygen. Have a low threshold for starting aspirin therapy if there's no contraindications, and my big contraindication would be an absolute allergic reaction or an anaphylactic reaction to this medication. And then occasionally it's uncertain on if the patient really did take a loading dose of aspirin, maybe they took some and vomited. So if you're anyway in doubt about the patient having actually taken in that level of aspirin, you can go ahead and repeat a dose. Recommend acquiring and transmitting a 12-lead EKG if your service allows for that. So if you have the equipment, the technology for transmission, and it's been approved by your medical director, we would definitely consider having a low threshold for this. And remember, you can have a wide variety of symptoms that actually can highlight acute coronary syndrome. In particular, women have been noted to have some more atypical symptoms. So not necessarily crushing chest pain, it may be more neck pain or some shortness of breath or even just palpitations. For patients that have a EKG that shows an ST elevation MI, this may be very obvious. You may see diffuse tombstoning changes, but we would recommend that you contact medical control and then confirm a plan for transportation. If you have a facility where you can perform a primary cardiac catheterization center and you can get to that facility within 90 minutes, the recommendation would be to transport directly to that facility, but this may change or may differ depending on your local resources. If a patient has nitroglycerin, you can assist the patient with that medication. Just make sure that you're keeping an eye on their systolic blood pressure and it's not too low and you wouldn't induce further hypotension. And if you do administer a dose and blood pressures get soft or decrease, you can always lay the patient down, provided they're not markedly short of breath. And this aspect of assisting with medications is what Dr. Dailey was talking about when he kind of alluded to the do the right thing aspect of BLS level care. All right, so moving on to kids. Who doesn't looking after a sick cardiac kid? It's one of my favorite things to do. Always scares the bejesus out of me. But the take-home point is use the resources to help kind of assess the child and hopefully mitigate some of your stresses. First thing I would say is when you have a patient that has a congenital abnormality, if they're home with mom or dad, typically one of those parents has spent hours and hours looking up their child's condition and is almost a mini subject matter expert. So utilize them as best as you can. Ask them what their typical baseline oxygen saturations are, because it's not uncommon for a preoperative congenital heart disease child to walk around with saturations of 82% and maybe even a slight bluish tinge to their color, and you're really going to have to rely on physical exam in conjunction with the patient advocate or parent to really give you the heads up for when they may be in a more extreme state. These children may have technology with them, implanted pacemakers or defibrillators, and then occasionally they will also have nasogastric tubes or surgical G-tubes placed to help them feed and gain weight. These children are prone to getting arrhythmias, so one of the more common ones would be a supraventricular tachycardia, or SVT, so consider having a lower threshold to obtain a 12 lead if that's within your scope of practice. All right. One of the big take-homes for this slide here is actually remembering the numbers. I'll be honest, this is quite tricky. It's something that I look up on a day-to-day basis when I'm in the pediatric emergency department, so it's nice to just have a quick reference. 60 and 70 are fairly easy to remember, but once you start calculating age times 2, it can get a little bit more challenging, particularly when you're dealing with the stressors of an unwell child. So moving on to asthma. Don't be afraid to administer supplemental oxygen if need be, and help assist the patient with their medications, whether it be albuterol would be the most common. You can go ahead and repeat a nebulizer or an inhaler 3 times as necessary, and if the patient is in a little bit more of an extremist, you can consider CPAP or positive pressure ventilation. Some asthmatics get so severe that the treatment of choice is intramuscular epinephrine. If you're verging anywhere in this level of illness, we'd recommend contacting medical control and obtaining an order for administration of IM epinephrine. All right. Unfortunately, we live in a world where narcotics have become a lot more prevalent. Thankfully, we have the tools to help mitigate this. So if you come upon a concern for an overdose, this is going to be the basic assessment and care that you're used to providing on a day-to-day basis. So ABCs, vital signs, open up the airway as necessary. You may consider checking a glucose if you thought it wasn't an opiate overdose. And then you want to consider utilization of a reversal agent, often referred to as naloxone or the trade name Narcan. The one thing that I would like to kind of point out is that you should use naloxone or Narcan for reversal if the patient really isn't breathing at all. So if you have a patient that's breathing maybe 12 times and shallow, but they're maintaining their oxygen saturations, you may just be able to ride that patient in with supportive care. But if that patient has a respiratory rate of 4 and their sats are 90%, you'd want to go ahead and administer naloxone in those settings. The way we give it these days is intranasal. So one of the more common forms is 2 milligrams, and what you want to do is divide that in half or administer 1 milligram in one nostril, 1 milligram in the other. And then if you're administering for a pediatric patient, in keeping with a lot of these ideals, you're going to use a half dose or half a milligram in one nose, half a milligram in another nose. Now, a lot of the region is using the 4 milligrams in a very small volume of 0.1 mLs, and Dr. Dailey has some here if anybody wants to play with them a little bit more. The key with this one is the volume is so low that you're not going to administer in 2 nostrils. You're just going to pick one, hopefully the biggest one, and just click and inject that 4 milligrams times 1, and then repeat the dose if necessary. All right. Moving on to sepsis or shock. A lot of our patients are unwell with fevers, belly pains, chest pains, and a wide variety of types of infection. So it's nice to try to identify this earlier and lead to more targeted therapy. So if you have patients that meet all 3 of these, and the first one would be suspicion for an infection. Second one would be altered mental status or low blood pressure. And then the third criteria there actually refers to SIRS, or a severe a severe inflammatory response syndrome, which all prognosticate for more unwell patients. It doesn't mean that if you have these, you always have an infection, but again, it's just a risk stratification tool. And worthwhile to note that on that last line, they comment on investigation tests or parameters. So white blood cell count or a bandemia, those are components that you're not going to have unless you were considering doing like an interfacility transport. So again, with the standard assessments, ABCs, vital signs, blood pressure, oxygen if necessary, attempt to maintain normal body temperature. So this may be warming up a patient if they're hypothermic, or maybe removing a layer if they're hyperthermic. And then you want to figure out the hospital that's the best location that can manage a critically unwell patient. Very similar for kids. Although we know that sometimes younger patients can be quite tricky in actually obtaining a blood pressure. So if this is the case, then you're going to fall back on some of your more some of your other physical exam findings, such as your how warm their peripheries are, what their capillary refill is, what's their mental status like, and then if necessary, administer oxygen. And then it's always appreciated when any sort of sepsis patients come in for a little bit of advance notice. I'm sure you guys have responded to some sick children out in the field, and it's always nice to have a little bit of a heads up or a notification you're going to be arriving on a scene with a sick child. Same goes for us here in the emergency department and the pediatric emergency department. Having just even those extra 3 or 4 minutes to get fluids ready and warm up an incubator or any of those other details can really be a big changer in that initial resuscitation phase. Here, again, we kind of commented that sometimes the vital signs are hard to remember, so I thought it was nice that they put this sort of chart in there for quick reference. And you can note that once you get to around the age 11 or 12, a lot of your vital signs are more in keeping with adults, which we're a lot more familiar with. All right. Tracheostomy. So I know even just in our area here, we have a couple facilities that are long-term care units for some chronically unwell patients. A lot of those have tracheostomies. They may be vent dependent. They often have PICC lines or central lines, and then they may have G-tubes as well. So tracheostomies can be quite scary. Thankfully for the BLS approach, it's actually quite simplified. So if you're transporting a patient, they're on a home ventilator setting, and something goes wrong, take away the ventilator. Just go ahead and hook up the BVM right to the tracheostomy tube. And then if you're running into problems with the actual tracheostomy tube, whether this is kinked, occluded, partially dislodged, then you just fall back again to basic training where you would remove that tracheostomy tube, occlude the stoma or the hole, and then perform your bag valve mask ventilations from the oropharynx. If you see a catheter that's out or kinked, maybe it has a hole in it, simple thing to do is just see if you can grab something and grab a hold of it so it doesn't move around or propagate further into the body, whether using tape or forceps or anything sort of similar. And then along those lines with G-tubes or gastrostomy tubes, if it's partially out, just go ahead and tape it into place, provided that's a feasible option. And if it's fully out, again, just an occlusive dressing over the aperture, and then you can consider some mild direct pressure if you had any problems with bleeding. One little tip that's not on the protocols, but if a G-tube comes out or a trach comes out and it's a long-term facility or even at a house with a parent that's really good with the child, it's worthwhile to take a note of what the original equipment size was. It just helps hospitals figure out what they need to replace, or if you're uncertain and it's feasible, just actually bring that device in even if it's not still connected to the patient. All right. Has anybody ever cared for or looked after somebody with a left ventricular assist device or a VAD? All right, that's always a fun experience. I'm sure, if I was looking after somebody in the field, I would be nervous, but I'd equally be nervous if I was looking after somebody in the emergency department. Thankfully, in a kind of more simplistic approach, 2 steps. First, listen over the chest, and if you're hearing a hum, that's good news. If you're hearing the hum and you look down and you see green on the actual device, that's when you start taking a nice sigh of relief. The other thing that you always want to do is still go back to your basics and assess your patient. So see what they're looking like. Are they sweaty? Are they unwell? Are they short of breath? We could talk at length about the different types of devices and how they actually propagate blood around the body. But basically, some are continuous and some are more pulsatile. Irregardless, on either type, it's quite tricky to get a blood pressure, so that's why you have to kind of fall back on some of your more classical physical exam findings to figure out if the patient's unwell or is just having a more routine issue. And I say routine issue, but there's almost no such thing as a routine issue with an LVAD. So even if a patient has an LVAD and they've twisted their knee, internally here, we speak to the coordinator, we let them know. If you want to do the same and give an early heads up to receiving hospitals, that's always much appreciated. Lastly, we often get questions on when do I do CPR in a patient with an LVAD in place, and really you want to try to reserve this until you're absolutely forced to act. So this would be one where if you're not hearing the hum, aka blood is not flowing through that pump, and at that same time the patient is acutely unwell. So think, this is an unresponsive, non-moving patient that maybe looks shut down, then you can consider CPR, with the big concern would be that you might disrupt the device. But if the patient's that unwell, you're kind of forced to act and you have to do something anyways. Things to mention specifically about the LVAD, and the patients themselves are pretty good with staying on top of this, but you always want to grab an extra battery. Batteries usually last a long time, but hey, it always helps to have a backup just in case. And on that note, make sure you change one battery at a time, otherwise you could lose power to the unit. And these patients, interestingly, can walk around in VTAC or VFib, and you'd never know it. So I'd consider having a lower threshold for an EKG if it's in your scope of practice. One other thing that's worth commenting on in LVAD patients, because they have part of the device that's actually external, we call that the line, this can serve as an area where infections can propagate in and become deep-seated infections. So if you have a patient with an LVAD that has a fever, highest concern for infection, again, advance notice if you're able for the receiving facility. All right, moving on to avulsed tooth. If you have an avulsed tooth, you found it, it's intact, and there's not significant damage to the oropharynx. So this is somebody that got an elbow and their teeth went flying out and their gums are intact. You can consider reimplanting that, provided it's an adult tooth. That same patient takes multiple blows to the face and their jawline is entirely disrupted. Maybe you take that tooth in with you to the receiving hospital, but understand the chances of salvage is going to be quite low. There's a couple techniques with this, and we're going to watch a quick video, but I just really wanted to mention these specifically to drive them home. So you always want to grab by the crown or the bit that we can see when we look inside our mouth. So stay away from the sharp pointed bit. That's where the ligament attaches. And if you're reimplanting a tooth, you'd want to give that area just a quick, gentle rinse with some saline. You want to avoid scrubbing or any sort of significant irrigation of the area, because you want to try to keep the ligament and those structures attached. And then you're just going to go ahead and push it into the socket, noting that if you have any sort of blood clot in that socket, you'd want to suction it out beforehand just to try to increase the chance that they may hold on to that tooth in the long term.
One of the newer protocols that a lot of people from different regions may not be familiar with is the avulsed tooth protocol. And essentially this protocol is intended to be used when you have a tooth that has become avulsed or has fallen out. In this case, we want to make sure that the tooth is intact. We don't want to be reimplanting any fractured teeth. And when you are handling the tooth that has come out, you want to make sure that you handle it by the crown and not the root. Clean off or rinse off the root itself. We want to be careful that we don't scrub it, because we don't want to take off any of the ligaments that may still be adhering to the root. So we're going to go ahead and just rinse it off. And then the other important thing is to examine the area in which you're going to reimplant the tooth to make sure that there isn't a blood clot there. If there is a blood clot, that blood clot has to be removed. So one of the ways that it can be removed is with the suction unit. You can just go ahead and take that blood clot out with the suction. And once that area is clean, you can simply go ahead and reimplant the tooth. When you do that, it's important to make sure that you look and see which is the inside of the tooth and which is the outside of the tooth, because we certainly wouldn't want to mix that up. And once
very important bit.
with that,
you know, try not to put the tooth in backwards. The hope would be that if you put the tooth in backwards, one, it may not want to fit back in, but if you did manage to get it back in and you took a quick look, hopefully it should be fairly obvious, unless somebody has really, really bad teeth to start with, and then you may not be missing much. Bleeding control. I know this is one of the more hotter topics of late. But if you come across any significant bleeding, first point of call, direct pressure on the site of bleeding with or without a hemostatic agent if you have it present. And if you're unable to control bleeding with direct pressure, because honest to God, a finger pad of pressure is often the best tool you'll have. But if you're unable to succeed with that and you have a tourniquet, you want to deploy that. And the current recommendation is, if you have one tourniquet, to apply it 2 to 3 inches proximal to the wound. And if that doesn't abate the bleeding and you have a second one, then you can go higher up the limb or more proximal on the body. If for some reason you weren't able to control the bleeding 2 to 3 centimeters proximal to where your wound is, and you only have the one tourniquet, then I would recommend you place it high and tight just to be done with it and give your best chance of hemodynamic control. And then the one take-home point, if you really think that there was life-threatening bleeding going on, put the tourniquet on once, put it on tight, check it and make sure it's tight, and then leave it alone until you hit definitive care. Moving on to the patella, we often joke these can be fairly fun to do, although it's often quite stressful on the patient. Maybe not as much fun as reducing a nursemaid's elbow in a kitty population. But most of the time, this is going to be a forced lateral dislocation when they kind of land on a flexed knee. So if you have this scenario, what you want to do if you want to perform a reduction method, you're going to grab the patella, whether it's medial or lateral, and then slowly start to push it back in its original place as you extend the knee. And you can often administer some supplemental analgesia if you had those capabilities. Patients often feel much better once the joint is back in place, but we would still recommend splinting and transporting to hospital for evaluation.
Let's talk about how to...
I'm going to go back to that in one sec. And then the last slide here we'll talk about is just assisting with prescribed medications. So the formulary specifically mentions sublingual nitroglycerin, albuterol or other beta agonists, rectal diazepam if it's been prescribed, epinephrine auto-injectors, or naloxone administration. But you can go ahead and assist patients with their own medications, with the one caveat that we'd recommend that you speak to medical control just to make sure it's appropriate for that exact scenario. All right. And I will leave you with the patellar dislocation and then run out the door. Apologies. Any questions before I head off? Okay, all right. Thank you so much, guys.
Let's talk about how to reduce a dislocated patella.
So usually the kneecap is dislocated when the patient hyperextends their leg, like landing from a jump. Almost always you're going to see it displaced laterally and the patient is going to flex their leg. To reduce it, you're going to firmly grasp the patella, yes, firmly grasp it, and simultaneously, while you're rotating it back medially, you're going to straighten the patient's leg out. As you can see here, it pops right back into place, and generally the patients are just a bit more comfortable after that's done. You'll want to provide a splint for comfort,